Hello guys, good evening all of you. So I am back again 6 p.m. We've got a decoded session. Eye images that we did through the past 1 week on Instagram. So I will be discussing those questions because Ophthal is all about images because whatever even in the clinic is all about what we see, right? So shall we start the images discussion? And please do try out the Let's Do MCQ series that I posted today just now on the channel, the YouTube channel. So you got a fundus image, look at the question, read the scenario and answer. Okay, so shall we start with our images? All right. Now this one, first you need to tell me what is this investigation. Okay, what is this investigation that you see? Okay, my reflection is seen on my phone. So what is this investigation? First of all, what is this investigation, bache? What is this investigation? Then we'll go to the finding. Okay, what is this investigation that you was able to see? Good evening, Vinod. Yes, very good. This is an OCT. See, optical coherence tomography. Yesterday in the retina quiz, there was a question which asked, which is that investigation where you can visualize all the layers of the retina. See, I can see all the 10 layers of the retina and a full thickness defect in the retina. In fact, I can see a little bit of the choroid, little bit of the posterior vitreous. Yes. So OCT, very good Kani, very good Kani. Very good, Vinod. Yes. So this is OCT. Investigation is OCT. So now you know OCT. What all can I actually visualize? I can visualize all the layers of the retina. I can visualize even the choroid. And I can visualize the posterior part of the vitreous as well. So here I see a full thickness defect in the retina. So this is the macular area. So this is a macular hole. Okay, very good. Now, don't get confused by the little cysts that you're seeing here. Yeah. See, the little cysts that you see here are intraretinal cysts. This is not cystoid macular edema. I'll show you another day cystoid macular edema. So, this is macular hole. Okay, this is macular hole. Can anyone tell me at least one cause for macular hole? Oh, that is so disturbing. Oh. One cause for macular hole, at least one cause for macular hole. At least one cause for macular hole. So now you'll never make a mistake, or you'll never make a mistake if you want to visualize all the layers of the retina. Then what is the investigation? The investigation is OCT. And one cause for macular hole. Okay, think about it and you can tell me. Now, another interesting image. I love this image. Okay, I love this. Okay, for all personal reasons, I just love this. So, what are all the findings you can see here? Can you all see the bilateral ptosis? Because my palpebral fissure height is decreased. What is palpebral fissure? I've time and again told you. Palpebral fissure is the area between your two lid margins. Okay, that is your palpebral fissure. Palpebrum means eyelid. The fissure between the palpebrum, that is palpebral fissure. So palpebral fissure height is obviously decreased here. It is decreased. And the palpebral fissure length or the width is also decreased. Yes, it's not as big. Okay, it's not as big. It's so tiny. Yes. So it is like a contracted eye. It's not contracted socket. That is different. Okay. So this is contracted eye. Okay. So the palpebral fissure appears very, very phimosed. Phimosis means contracted. So does it appear like that? So do you have a decreased palpebral fissure height and decreased palpebral fissure width? Okay. Now, the next finding that I'm going to show you, the moment you appreciate it, you feel, ma'am, I understood this. Give me a thumbs up so that I can teach you the next finding. So now, can you see an epicanthal fold? Can you see an extra skin over the medial canthus? See, look at my medial canthus. I don't have an extra skin. Yes. Do you see that extra skin here? Do you see that extra skin fold over the medial canthus? Give me a thumbs up if you acknowledge this finding. So far I have taught you 3 findings. One is palpebral fissure height decreased, palpebral fissure width decreased. Then there is a extra skin fold. Okay, so this is called epicanthal fold or epicanthus. Over the medial canthus is something. But normally an epicanthus, you all must have seen Down's babies. In Down's babies, there is this epicanthus. Okay. Now, but that fold will arise from the upper lid and go down. But here it is ulta. See, it is going from the lower lid. That skin fold, extra skin, can you all see that? It is arising from the lower lid and going up. So this is epicanthus inversus. This is epicanthus inversus. Pakka, everyone? Very good, Shweta. Yes, very good. Cube, this is not microophthalmos. I'll tell you what is microophthalmos. Just follow with me. Okay, follow along with me. Now, look at the distance between the 2 medial canthi. Is it increased? Yes. So I have a increased separation or increased distance between my medial canthi. So this is called telecanthus. Okay, so I have telecanthus. So what is the 4th finding in this image? Telecanthus. So first I showed you decreased palpebral fissure height, decreased palpebral fissure width, epicanthus inversus, then telecanthus. Yes. Now, the definition of telecanthus, you have 2 criteria in the definition of telecanthus. Okay. One is increased separation between the medial canthi. So, increased medial canthal distance, but normal interpupillary distance. Okay. Normal interpupillary distance. In fact, we say the medial canthal distance should be less than half the medial canthal distance. That is how it is normally. Okay, so it should also satisfy that criteria. Okay, now I also want you to see there is on the lower lid on the lateral side. Okay, so this is the right eye. Okay, for you it might be left eye because it's laterally reversed. So can you see this part of the lower lid margin little bit everted? So there is a lower lid ectropion. Okay, there is a lower lid ectropion. Yes, very good, Shweta. Okay, now can you see the flat nasal bridge or the root of the nose is flat, and also the superior orbital rim is flat. See, it's sharp. Okay, it's sharp, especially Indians, it's very sharp. Yeah. Now, the superior orbital rim is flat because the superior orbital rim hypoplasia is there, and also there will be flat cheeks because malar hypoplasia. These bones will maxillary hypoplasia. Malar flatness. Cheek will be flat. Are these findings clear? So this is BPES. B, blepharo. Blepharo means lid, eyelid. Phimosis, it is contracted. Blepharophimosis, BP. E, epicanthus. Inversus, the eye is not included there. So blepharophimosis, epicanthus inversus syndrome. So this image is classically blepharophimosis, epicanthus inversus. Okay, BPES. See, there is no ocular motility problem here. There is only ptosis. Ocular motility is absolutely normal. Yes? And okay, now what about BPES types? We have type 1 and type 2. In which type do you have PCOS? Which type is associated with PCOS? One question for you. So you'll have to tell me which type is associated with polycystic ovarian syndrome. It's not blepharophimosis plus ptosis. Blepharophimosis itself means there is ptosis. Okay. All right. So somebody, Krishna, yes, Krishna Devi, congenital blepharophimosis. Bit of blepharophimosis itself is congenital only. This is a congenital problem. Okay. Okay, Rangesh, retinal tear. Okay, I'm just reading your previous answers. So macular hole, see, retinal tear is usually in the periphery. So retinal tear can occur because of blunt trauma. So I'm taking your answer and giving you the points. Okay, very good. Blunt trauma can cause macular hole. Okay, so the answer to my previous question. So Rangesh, very good. So retinal tear usually in the periphery, but when we have retinal tear in the center, that is macular hole. Okay. High myopia, Vinod, yes. Pathological myopia, yes, you can get macular hole because the retina is very thin. You can get, what are the other options? Strawberry, very good. BPES, okay. Syndrome, very good. See, microphthalmos is completely different. Microphthalmos is when the eyeball is small. The axial length of the eyeball is small. In BPS, although the eye appears kuti, okay, it appears so small, chotu, like this, the eyeball itself is not chota. Axial length will be normal, okay. Okay, who is that? All right. Okay. Let's move to the next image. So this image came in May INICT. So that is why I'm giving you here. So you can see an air bubble, a gas bubble in the anterior chamber. Okay, so that means it is intracameral. Anything in the anterior chamber, it is called intracameral. Okay. So here I can also see the cornea edematous here in this area, in the inferior area, typical inferior paracentral area. There's a lot of corneal edema. So that means this is acute eye drops. So acute eye drops can occur actually in three conditions. Okay, acute eye drops in the cornea in ophthalmology. We're not talking about Meniere's disease of ENT. So acute eye drops can occur, as you all know, in keratoconus. Yes, because of the descemet membrane tear, the aqueous seeps into the corneal stroma and there's an edema. Yeah, typically in the conical region, in the apex of the cone. You can also have it in congenital glaucoma. There also you're having you're having descemet membrane test, can happen there also. Can also occur in excuse me, pellucid marginal degeneration. Okay, so acute eye drops can occur in all these three conditions. What are the three conditions you can have acute eye drops? Basically, wherever there is either corneal thinning and there is this descemet membrane tear and the stroma there is accumulation of aqueous humor, or because there is increased IOP and the descemet membrane tears as in congenital glaucoma. So what are the three conditions where I can have acute eye drops? One, keratoconus. Number two, congenital glaucoma. Number three, pellucid marginal degeneration. So for managing acute eye drops, what is this minimally invasive procedure? I can just inject SF6, sulfur hexafluoride. Okay. So that is going to cause decimetopexy. It is going to cause a reattachment of the descemet membrane, which is torn or rolled out. So this is, it could be any gas. In this case, my option was SF6 and most commonly used is also SF6. Sulfur hexafluoride. Okay. So this is intracameral SF6. See, if you have microphthalmos, then we'll have to investigate and then see what is the problem, and based on that, if we can manage those problems. See, it's not like a cookbook recipe. Microphthalmos means do this. We'll have to see what are the other problems. All right, now look at this image. So this image, you see the dandruff. Guys, any of you have dandruff? When you have dandruff, it spills all over, no? It's exactly like that. So nasty that is. I mean, because I have dandruff, I know how it is. So I'm not body shaming anyone or dandruff shaming anyone. So if you have these kind of dandruff-like deposits on the pupillary margin, on the pupillary ruff, and little bit one or two you can see still on the anterior capsule. You can't really see the target sign on the anterior capsule here because the pupil is not dilated. Pupil is just normal size. So what is this? Very good, strawberry. Very good, strawberry. Very good, Kani. Very good. So this is pseudo exfoliation. Okay, pseudo exfoliation, where you get this dandruff like deposits on the pupillary margin. So for the same reason, the pupil will not dilate properly. There will be poor dilatation in case of pseudo exfoliation. Yes. Okay, now another one was neuro-ophthal image that I had, actually it was a question and I just wanted to teach you this. So when you look at this image, yes, you see this corpora quadrigemina. Yes, 4 bodies. Quadri means 4. You have 4 bodies here. So the first, the upper 2 is called as superior colliculus. This is inferior colliculus. So this is midbrain. So you're seeing the midbrain. At the level of midbrain, superior colliculus is where your third nerve nucleus is there. That is your oculomotor nucleus. And at the level of inferior colliculus, you will have the fourth nerve, that is trochlear nerve. So you can see the dorsal exit of the trochlear nerve. The only cranial nerve to have dorsal exit is your trochlear nerve. Is that clear? So these two are superior colliculi, at the level of which you have oculomotor nucleus. Then there is this inferior colliculus, at the level of which you have trochlear nucleus, cranial nerve 4 nucleus. So you can see the cranial nerve, trochlear nerve emerging. In fact, this cranial nerve would have arisen from this side cranial nucleus. Okay. So already when it emerges, even when it emerges, there would have been a decussation and it emerges. So let's assume this is a right side. So if this is a right sided trochlear nerve, or according to, yeah, okay, let's say this is right sided trochlear nerve, it would have come from left sided cranial nerve, cranial nucleus. So similarly, this one left trochlear, okay, as you see it, okay, whichever side. So if this nerve, trochlear nerve, it would have arisen from this side nucleus. Is that clear? That is why you have the cross innervation of superior oblique, because of the decussation that happens right at the time of just emerging from the nucleus. When it just arises from the nucleus, there itself it crosses over. So when it comes, so dorsal exit, it comes forward. Yeah. So when it emerges dorsally, it is already crossed. Decussation has happened. Is that clear? So that is why if I have a problem in my left cranial nucleus, trochlear nucleus, yes, I will have a right SO palsy. Is that clear to everyone? So many hearts are coming. Oh my God. Oh my God. Okay. So understood. So you'll have a decussation. So that is why we have a contralateral superior oblique innervation. So that is exactly the reason why if I have a left-sided nuclear level palsy for trochlear, fourth trochlear nuclear palsy, I will have a contralateral muscle SO palsy. Is that clear? Okay, so we are done with the images. I guess we had few images. Yeah, so we've discussed, all right, we discussed 5 images. Good enough. So I hope you're confident with the images as we go. All right, so tomorrow you've got neuro-ophthal quiz on the Telegram group. Now how to join the group? There are, I put the links everywhere. So you can join our Telegram group and take the quiz. Quiz will happen at 6 p.m. and the discussion will happen the day after. So that means I will see you on Tuesday morning 11 a.m. So we have our 11 a.m. ritual. So 11 a.m. I will see you with discussion of the neuro-ophthal questions that I will be posting tomorrow in the quiz. And in the meantime, again, test and discussion, you can join us. Please ping us on the link. All right. So you have a good Sunday, guys. I will see you on Tuesday. Ciao. Have a good evening, all of you.